All right, welcome, you guys. My name is Dr. Reed Nellis, and I want to start by saying thank you for taking the time to download this free mini course, this teaser of sorts for understanding and treating shoulder injuries for rotational athletes. This next 30 minutes to 45 minutes, we're going to be discussing the course in its entirety, the full length course, whether that's the live webcast version or the downloadable version, and what you might expect in that. From this 30 to 45 minutes, I hope you learn something, as well as maybe gain an appreciation for what the full course content will deliver. So, without further ado, let's jump right into this. I'm going to start with who am I? Okay. So, who am I to deliver you anything? Who am I as a person? And this all starts with a brief introduction, right? I'm first a human, a husband, and a father. Then I'm a chiropractor and a movement nerd. I think understanding that we're all human first and we have priorities outside of our profession is crucial to understanding our patients and clients and how they work too. They have lives outside of their shoulder injuries being a rotational athletes. And we need to understand that and appreciate that within ourselves before we can understand and appreciate that within them. Okay. Then, like I said, I'm a chiropractor and a movement nerd. This is me in all these pictures you can see on the right hand side there. This is how I got interested in this healthcare profession is through my own injuries. So how I got here, again, a lot of my own injuries led me into the healthcare field as a patient. What that illustrated to me is the need for more movement-based minds, more thinking outside the box minds. A lot of my injuries, ACL, MCL, LCL, broke my back a couple times, major TBIs, separated shoulders, broken bones galore. I mean, everything, right? Didn't get better under the modern medicine care tactics and the modern medicine care protocols. And a lot of my providers that I sought out thought outside the box. Not to say that they were snake oil voodoo docs or anything like that. They just saw me for who I am, a 16 to 18 to 22-year-old athlete, and treated me like that. Okay. So treating people how they deserve to be treated is something I'm going to be touching on this full course. I ended up going to chiropractic school, met a guy by the name of Dr. Stark, awesome mentor of mine, and led me into this sports realm, which I was already kind of interested in. But working with athletes is something that he really opened my eyes to with a trip to Italy, where we were able to work with the athletes at the World Games in Legnano, Italy. I believe that was in 2015. So that combined with my constant questioning and ADHD and the fact that I like wearing gym shorts or joggers to work with a t-shirt led me into opening my own practice. So I own and operate Minnesota Movement, located in Minnesota. Part of the name, it probably should be in that location. And in this facility, we're able to treat people how they deserve to be treated. Okay, taking the time and effort to go through a proper screening and assessment and work with them however we need to get them feeling and moving better. Okay, so that's a little bit about me. What we're going to be talking about throughout our course is the rotational plane, specifically as it relates to shoulder injuries, right? Um, when I started developing this course, I started thinking about like who is a rotational athlete and what qualifies somebody as a rotational athlete and what does that mean? Uh, Power and responsibility is what it means to me. And we'll discuss the components that make up this power and responsibility in a couple slides. But the transverse plane is where we get all of our power from, whether we're hitting a golf ball or a baseball bat, punching, swinging, dancing, yoga, any of these powerful movements come through the rotational plane, right? Try to throw a baseball as far as you can by just going into the front and back sagittal plane. You're not going to get it very far, okay? And effective, right? But with that power comes great responsibility. We usually get injured in this rotational plane, and this takes a brunt on our mobile joints, such as the shoulder and the hip, okay? So we need this balance between the two, and that's why I felt like this course was necessary. Our outline for the entire course, as well as today, is going to be, like I said, discussing who is a rotational athlete, what qualifies somebody as a rotational athlete, and then briefly going through the common shoulder injuries. Briefly today, but in the full version, we're going to go through the commonalities of these injuries and what we might expect to see with them as far as mechanisms of injury and where we can glean information from that to lead our screen assessment and treatment as well. This all begins, though, with a patient history intake and how we might ask better questions to get better answers, okay? And then we can get into our screening and assessment, not only just locally, what the shoulder is doing, but globally, what the big toe might be doing to the shoulder, or more proximally, what the hip or thoracic spine or our breathing patterns might be doing to the shoulder, right? Then the second half of our full course, or the second portion of today's little session, is going to be discussing therapies, treatment strategies that you can demonstrate in our course. And I will demonstrate and show applications for within the live course that you can take home and use on Monday or Tuesday or whatever client and day that you choose to use. Okay. So we're going to have live availability to practice these techniques as well as exercises and the like. Okay. So with these manual therapy techniques, we're going to be discussing compression, decompression, kinesiology taping, and corrective exercise strategies. Brief disclaimer: I hate the word corrective exercise. Words of corrective exercise that implies that something was not correct to start with. More so, just movement strategies that we can get somebody moving and feeling better. Okay. So our first chapter: who qualifies as a rotational athlete? Is it these studs on the field or pitch or sand court or golf course or dance stage or baseball diamond? Or is it pretty much anybody? Okay. Um, the reason I chose rotational athlete in the name of this course is because it overarches everybody. This course could have easily been understanding and treating shoulder injuries, but it's not. We should look at everybody as if they are a rotational athlete, because walking deals with anti-rotation, dissociation from upper half and lower half. And this is why I think it's important to note everybody's a rotational athlete. And everybody should be treated like a professional rotational athlete, whether they're in T-ball, squirts, middle school, high school athletics, collegiate, recreational, coach to 5K, weekend warriors, or professional athletes. They all deserve the best care possible to be rendered unto them or with them in mind. And I think this is what our course is going to help us achieve. Trust me, I know you guys are trying to give everybody the best care possible already, but sometimes we get lost in the minutia of which step do I take next? This protocol that I learned in school says this, but then clinically, anecdotally, I see this. Hopefully, we can combine all this stuff together to make this process a little bit less confusing and more accessible to you. Okay. Another quick note on that is I think it's important for me to illustrate that I didn't come up with much of this information. All knowledge is stolen knowledge. Everything we know about the world is out there at this exact minute, right? We're learning more as we go, but I just put all this information for this course to a more digestible manner for you so that you are able to comprehend and apply it clinically or in real day life. Okay. The research that we're going to go through, I did not do the research. Okay. We found it on the internet through hours of scouring, not biased research, right? All the orthopedics and the ranges of motion, the assessments, they're all borrowed from somebody else, just put into a more digestible manner to comprehend today. So when we're talking about rotation, I mentioned this earlier, we must have this equation that leads us to this responsibility or efficiency and power. This comes from adequate stability and a balance between mobility, fine balance between those two, and that balance is generally motor control. That's what drives stability and mobility. So we need these three things to have an effective rotational or transverse plane. Touching on stability versus mobility, and by the way, there's a big difference between mobility and flexibility, which we'll get on in the full course, okay? But you can't have one without the other. Try using one muscle to its full range of motion, maximum capacity, and not feeling even the slightest stretch or mobility across the opposite muscle. We see this all the time with PNF stretching and some yoga moves and things like that. But what we're going to touch on in our course is the fact that the body will rob Peter to pay Paul. Meaning, in our joint by joint approach of looking at the body, we have joint spaces or areas that generally need more stability or generally need more mobility. If we take the thoracic spine, for example, that generally needs more mobility. If it's losing its mobility and it's becoming very rigid and stable, it's going to try to steal mobility from the adjoining joint spaces, namely the scapulothoracic joint or the shoulder blade. That shoulder blade becomes very loosey-goosey, which it needs to be stable in order to provide global mobility through my glenohumeral joint. So if we start proximally and work our way out of the body, if we start losing the general needs of these joints, we have an issue. Okay. And this is where this quote on the bottom comes into play. You can't shoot a cannon from a canoe. We need a stable foundation to launch something or mobilize something from. Right. We'll go upon this further in our course. Then comes in motor control, the balance between stability and mobility, as well as timing and rhythm or co-contraction of certain tissues or muscle groups or fascial lines. Okay. This muscle sequencing allows for fluency of movement. When I think of fluency of movement, I think of like a figure skater in the Olympics or a skier or snowboarder taking off and doing 4 flips and 6 spins in the air. It looks easy. They make it look effortless. That's A, because of time and repetition with practice, but B, they have this predictive capacity in their brain where they know exactly what part of their body is going to be contacting what part of the ice or snow or air at any given point. It's called air awareness. And this predictive capacity we all have, and it's in order to survive. If the snowboarder's up, 60 feet in the air, they want to survive this landing, get a good score on their run. But all of our predictive capacities are first and foremost to survive, then to move, right? And with this predictive capacity, I love this example. We have knee-jerk reactions. What do we see here on the page? An elephant. Boom, knee-jerk reaction, an elephant, not threatening, not going to endanger my survival rate or anything like that. But if we look a little bit longer and take some time to gander at this image, we start to kind of assess like, oh, black and white dots, two tusks, long trunk, yep, still an elephant. Oh, wait. How many legs does this elephant have? And where are these legs? Are there 5 or 4? And is that a leg? We start getting a little bit more confused. But our knee-jerk reaction of, boom, an elephant, move on, was for survival. Our next predictive movements in our brain, or our next predictive algorithms that we're producing in our brain, are to cognitively dissect what is in front of us to make it more applicable in our immediate moment. Okay. And we'll touch on this a lot further of how the brain works neurologically with pain and movement being key in the full course. Within the full course, we're going to discuss our injuries at length. Again, the commonalities and the mechanisms of injury. But briefly for today's course, we know our anatomy. In the full course, we'll go through the glenohumeral joint and what its general needs are and where it can most likely get injured and how these mechanisms play in, as well as the AC joint, SC joint. And as you can see here, the injuries, AC separation, osteolysis, Fuchs as being the most common of all shoulder injuries, right? And what the joint space is made up of. Is it more of a meniscus thing? Is it a ball and socket thing? How might that play into not only the injuries, but how we might treat these injuries and treat this area as a whole, okay? And then the scapulothoracic joint being the last of the local joint spaces. Probably one of the most confusing joints because there's so many degrees of scapular plane motion and things like that, which we'll touch on in a second. But we always try to take people out of it for some reason, and it needs to be in a certain area. It gets confusing, and we'll hit on this big time in the full course. One of my favorite joints by far, okay? All of this anatomy and all of this understanding doesn't mean anything unless we understand what the patient's needs are and their goals are, and this comes from the patient history. Winston Churchill said that history is told by the victors. We're seeing the losses, okay? What are we learning about their wins? And that's important. But what else are we learning about the losses? What didn't they achieve? And how might that play into how we can render care with these individuals? So what I'm getting at here is we must listen more than we speak. You've heard this before. You try to do it your best when you're taking a patient history, but ask open-ended questions. Ask better questions to get better results. It's not always just on a scale of 0 to 10, 10 being the worst pain imaginable, 0 being no pain at all. Where would you put yourself? Why? Why do they have pain there? What is that pain derived from, and where is it representing to them, whether it's emotionally or socially or cognitively or physiologically or biologically? That's pain too, right? But there's other aspects we need to look into. William Osler said this, and I think we've all seen it before, but we'll look at it with a different lens, okay? If we listen to our patient, he's telling you the diagnosis. And if we listen long enough, they might just tell you how to fix it too. Okay, we've all heard this, whether in school or from a mentor, or maybe you figured it out in your clinic already. But the point here is just shut up. Okay, we'll talk about research that says if we give our patients and clients 6 more seconds to talk about their issues, they're going to tell us these things, not only what the diagnosis is, but how to fix it, right? Quite often, we as clinicians and providers interrupt our patients before they get this extra 6 seconds to tell us these things. We need to shut up, okay? And we'll talk about that further in the course. The other aspect that I really like bringing up, and I really am excited to show you guys in this mini series or this mini course, is this bullet hole misconception. Asking better questions to get better answers. Okay, we need to think outside the box. What else have you done for this shoulder injury? Well, I've already seen PT for this and massage for that, and we did some cupping and we did this and we did some bird dogs and dead bugs and things like that, and none of it worked. Well, great. That's fantastic news. Thank you for sharing that with me. Because guess what? Now we're not going to do any of those things that didn't work. Or maybe they didn't work because you weren't working or something like, and we can work with that, right? We have to understand where they've already been and not just beat a dead horse. Okay. So I like saying if it was going to work, it would have started by now. Oh, you saw a chiropractor for 6.5 years for neck pain. What did that do for you? If it's 0% better for 6.5 years, clearly if it was going to work, it would have worked by now, we would hope. Okay. The other questions I like asking, what can't you do? AKA, what's the worst thing you can do? That's your objective outcome measure, right? If it hurts your shoulder to reach up overhead to grab a jar of cookies every night when you want to eat cookies, well, this is your assessment and screen and your orthopedic test specifically, which we'll touch on in a second. But this is your goal now, reaching up to that jar of cookies. Okay, what are their goals is a very crucial question to be asked. So this bullet hole misconception is ask different questions, get different answers. The backstory on this airplane here is in World War II, over 100 airmen, 45 were killed, 6 were seriously wounded, 8 became prisoners of war, and only 41 escaped unharmed. That's stats that I had to read, but that's huge to me, okay? A lot of these airplanes went down. Of the airplanes that went down, they noticed that the fuselage, the outer wings, the tail were the ones that were coming back with bullet holes in them, okay? So when they started looking at where to put extra armor on some of these planes, keep in mind weight and the ability to fly long distances and things like that, the obvious answer was to add armor to the fuselage, the outer wings, and the tail. But a guy by the name of Abraham Wald looked at these airplanes and said, wait, you guys are asking the wrong question. You guys are looking at the airplanes that made it back to base, the ones that survived. Okay, again, Winston Churchill, history is told by the victors, right? We don't need to put any more armor or weight on the areas that were able to make it back. We need to put on the exact opposite locations of the plane. We need to put it in the nose of the plane, between the fuselage and the outer wings of the tail, or the outer wings of the plane, because those are the planes that are down in a field somewhere in France or over the water or wherever, right? Those are the planes that didn't come back. So if we ask different questions, we can start getting different answers, okay? This brings us into our screening process. A screen is looking for the low-hanging fruit or the biggest elephant in the room. It's a quick view from, speaking in plain terms again, 50,000 feet up. What's the biggest issue that we can see with a global pattern of movement? Then what we can do is take this into an assessment where we can get qualitative or quantitative data or measurable data from. We'll touch on that more in just a bit. But understanding that a screen is what is the issue is how I kind of like to dumb this down. And an assessment is why is the issue there? What patterns allowed this chief complaint of sorts to arise? Okay. So our movement assessment comes next, and we'll go through a bunch of examples and demonstrations of how to perform some of these in the full course. But this tells us why and how much, right? This data not only gives us something to create buy-in with the client or patient and say, hey, this is where you're at, this is where our expected range of norm is, or this is what your right side is doing versus your left side. Can you see the issue here, right? That's buy-in process. But it also gives us objective outcome measures to harken back to a visit in or 2 visits in or within that same visit. What measurable changes did we achieve, okay? So in our full course, we're going to go through a glenohumeral assessment and a acromioclavicular assessment, sternoclavicular assessment, scapulothoracic assessment, and we're going through all the active range of motion, passive range of motion, your orthopedic tests that you learned in school. But how else do we use this? We're not just going to take every single person with shoulder injuries through every single one of these tests. So what we want to think of is what we learned in school. What are these orthos that are relevant, and what information are we even trying to figure out from them? If we're just going through the motions of doing all these tests just to gather information that is useless to us, it's a waste of time, money, and effort on your part and their part, right? So figuring out ways that we can get digestible and effective information is what we're going to be delivering in this full course. Okay. Quickly, to give you an example, the scapular plane, nice little clinical pearl here that we kind of thought up, is I came from a chemistry background in college, so I'm not good at it anymore, but the right-hand rule stuck out to me when we're learning about the scapular plane, right? Because the scapular plane is super important to not get injured with, okay? If we take our scapula out of the scapular plane, we have an increased risk of injury, and the research backs this up. But the scapular plane sits at about 10 to 20 degrees from the vertical or frontal plane, right? Internally rotated 30 to 45 degrees from the coronal and frontal plane, coronal and frontal plane, sorry, and tipped anteriorly 10 to 20 degrees from that frontal plane. Okay? So if we try taking it out of that plane, which it has its own name, we try putting it in the sagittal plane or in the frontal plane, or knitting it into the rib cage or your spine by just retracting your shoulder blades as much as you can, we actually could be increasing the likelihood of injury from there. So with this plane and this right hand rule, if we were to take our right hand and place it on the back of somebody's scapula, their right scapula per se, or especially, we have three different axes that we have range of motion in. And forget about the exact degrees of where it's supposed to sit statically. If we're thinking dynamic range of motion, if I were to rotate upon my index finger here, that would be protraction and retraction, right? If I were to rotate upon my thumb here, that would be more anterior tilt or scapular winging, or posterior tilt or tucking down into the rib cage with the likes of serratus anterior, right? And then my middle finger here, that would be more elevation or upward motion, right? And depression or shrugging and unshrugging the shoulders, okay? So it's simplifying how we view some of these joint spaces and some of these assessments is very, very necessary, really. Unconfusing or getting away from the muddled minutia of the shoulder, because it can be difficult and we shy away from it because of these difficulties. If we can make that easier as clinicians, it's going to be easier to treat the patient and client. Okay. After our local assessment, we get into global assessment because the body moves in harmony and continuum. We need the entire myofascial network and this biokinetic chain moving as one unison for any athletic endeavor. Okay. This comes from the likes of Thomas Myers, the research community as a whole, and a bunch of other people, Mike Boyle and Charlie Weingraf, that we'll mention in the full course. Okay, but I really love this quote by Thomas Myers. The human body has one muscle in about 600 or so different compartments. I really like thinking of this meat bag being driven by our brain as a vehicle, right? Like we're just one bag of meat that we've dissected and named into 600 or so different compartments. Well, that's all fine and dandy, but it all has to move as one, right? The sum and the parts kind of idea, right? We need to add all these things together because the deltoid does not fire standalone, right? We need co-contraction of my left glute to make sure I'm balancing if I'm lifting up a dumbbell to my right side of my deltoid and my supraspinatus and everything else, okay? So looking at the entire body via these anatomy trains, as Thomas Myers calls them, and especially the spiral line, or what Rock Tape calls the performance functional chains. So these chains or these lines are across the body going diagonally. So from opposite shoulder to opposite hip, both in front and in back. Okay. So my right shoulder is directly connected to my left hip, big time. Okay. And when we're looking at these global assessments, we have to understand this because of the victim versus culprit idea. Sometimes where the issue is, my shoulder, is because of a completely separate issue somewhere else. And that is the culprit that we need to go after because our shoulder is just compensating and taking the brunt end of things. Okay? So at the end of the day, the best test for any person is the one that's specific to that person or specific to the patient or client in front of you. I bring this example up when I'm teaching a lot. I have a test that I've reproduced on probably at least a dozen different swimmers now called the Leah test, because I had a patient, with their permission to be shared, by the way, named Leah, who came in and she said, "Yeah, doc, it just hurts when I do this." Well, what orthopedic test is this? Especially with a claw, okay, because she was working out with the stability ball and everything. It hurts when I do this right here, okay? That's not it's a combination of orthopedic tests, right? But because of that combination, that's the only, I mean, we went through all of our other Hawkins, Kennedy, Jurgensen's, all these other orthopedic tests. Nothing else was positive. But this, time after time, reproduced pain, okay? So that now became the Leah test. And she was a butterfly swimmer. So it makes sense. Positive for impingement. Okay. And that test was specific for that individual. And if we can look at our screening and assessment, local and global, specifically with the person in front of us, from their patient intake, from their chief complaints, that will help us save time, money, and effort on our treatment. Okay? So this local test or this local assessment that we're going to go through in our full course is separating the upper half versus the lower half, dissociation between our two halves of our body. For example, and there's going to be more demonstrations that we'll practice in the live course, this open book test, looking for fluency between dropping one part of our body down to the floor compared to the other. There's a plethora of different movements and assessments that we can go through with this, but this is, again, just a good example of what we discuss in the class. The hip assessment, one of my favorite ones is looking at how well these glute muscles are able to extend through the ball and socket femoral acetabular joint. Okay, we can do isometrics, eccentrics, concentrics, and how does it all relate to the shoulder? If my hip, my ball and socket joint, isn't extending as well as it could or should, or compared to the opposite side, my low back, my thoracolumbar fascia is probably going to be on tension or more taut because the pelvic tilt is making up for that lack of extension. Okay, hopefully you guys are following me here. As we continue moving up that chain, maybe my opposite shoulder is now more locked down or hyperstable through that scapulothoracic junction, and we're not able to impart more distal mobility through our ball and socket joint. Or it could be a different other thing, right? Looking at it with a wide open lens allows us to see these things, all right? And then the last one we'll discuss in our full course is breathing. How might our breathing affect our shoulder? Well, if we're apically breathing or sighing the entire time, our sympathetic nervous system is going to be driven through the roof and we're no longer resting and digesting. But you can appreciate how much the upper trap and levator are going to be overused throughout this, as well as the scalene muscles, the SC joint, the AC joint, all of that. Okay, so it does have a huge role, and we'll go through a full example in the full course of how to look at breathing and what this might tell us from there. Like I mentioned, the second half of the course is going to be treatment strategies, whether that's hands-on, whether that's a little bit more passive, or corrective exercise in nature, movement strategy in nature. The second half of the course will be going through that. So to start, we have to get this off the bat, right? We have to be informed yet open, persistent and believe in ourselves yet malleable to any changes, okay? We don't always have the right answer. I tell providers and clinicians all the time when I'm just chatting with them or working with them or teaching with them like this, you will not fix, if you can even legally say that word, you will not fix 100% of the issues that walk through your door. You're only the answer or the solution to the issues that you are the solution for. Meaning, we have to know when to refer, what we're good at, what we're bad at, and all of these things, okay? Being able to be open to change either within yourself or referring out is crucial to getting people better. If we're changing within ourselves, looking at our modalities, whether it's decompression or compression, tape or floss, or tape or exercise, being able to change and adapt on the fly is something that I think we will discuss at length, and I think you will get a great appreciation for, and hopefully, again, less confusion with in your clinical practice. Okay? So with our treatment strategies, we're going to start with decompression, aka cupping, brought to you by the likes of Michael Phelps. I think he exploded the cupping scene, at least in the US here. So, but cupping, we could cup for a lot of things, and it's not just removing stagnation and creating this therapeutic bruise upon the skin. And we'll go through the history and the understanding of mechanisms of how the cups work in that full course. But one of the biggest reasons cups are used is for pain management, mitigation. Okay, it's important for us to understand that pain is not felt in the tissues. Pain is felt in the brain. Pain is just a signal to get your brain's attention and teach us something. That's the most important thing that I think we can educate with our patients, is that pain is okay. Pain, according to Mark Manson, can be healthy. Pain isn't always bad or undesirable. Stubbing our toe makes us learn how to walk into fewer tables, or hopefully move that table away from where you can stub your toe into it repeatedly. Okay. Rejection and failure teaches us how to avoid making the same mistakes in the future. You guys have ever had your heart broken by a guy or gal who cheated on you multiple times? I'm guessing if you're in a relationship now, it's with somebody who's a little bit more trusting and doesn't, or trustworthy, I should say, and doesn't have any of those same characteristics. You learn from that painful, heartbreaking experience not to go down that same path again, or not to walk into the same stupid table. Okay. So pain can be healthy. And this is what we discuss in our decompression and compression and kinesiology taping pain sections. We can also use decompression or cupping therapy for tissue mobility. In the full course, we will discuss how to find an optimal vector, whether that's alleviating or exacerbating, and when or why to go into that restriction or away from that restriction, as well as scar and neural mobilizations that we can decrease pain, but increase the pliability of that tissue so that it's not going through this painful arc or allowing more global ranges of motion, thus athleticism. Okay? We can also treat movement. Yes, treat movement with cups. Eric Cobb said this quote, and I really love it, and applies to basically everything I do every single day. As the quote kind of says, we're all treating neurology whether we know it or not, or when Eric told us this in person, whether we like it or not. Whether you like it or not, you're treating neurology. You're treating something neurological. The brain always has a place in our treatment strategies. Okay. And what we're getting at with treating movement with decompression or cups is external cues. Using the cup not as a decompressive strategy whatsoever, but as an external cue, something neurosensory touching the body, haptically learning in order to move more efficiently. Nick Wickelman's research in his book, The Language of Coaching, brings up Dr. Gabriel Wolf's work, and it shows that efficiency comes through external cues, not internal cues. So the example we have here is, if we're rounded through the shoulders, we could easily tell somebody to pinch your shoulders down and back. Well, we're losing the scapular plane there, so not a good cue to begin with. But if we are going after that range of motion, maybe telling the person to stretch the front of the shirt, feel that the cotton on the front of your chest stretch, and that's going to provide a more efficient outcome, a faster, more predictable outcome for this patient or client that we're working with. Instead of using a shirt, we could easily use cups too. Can you feel this cup on this shoulder blade? Yeah, great. Can you feel the cup on this shoulder blade? Yeah, great. Bring them closer to each other, okay? And they can go whoop and feel that tension. We can add a regressive strategy or provide assistance with maybe like a rubber band around these to help that sensation of pull between those two scapulae, right? Or progression, adding in manual resistance so that they have to fight against that to get those shoulder blades back. And it's all about what they feel best, what gets the best predictable outcome. Okay. Switching gears into compression, this chapter we start discussing more neurologically how the tissues adapt to change. Okay, gone is the idea of mechanically just beating and smashing tissues into a pulp that relaxes and feels all melty. Right? It doesn't work that way. I wish it was that easy. We'd all be a lot better at our jobs, but it doesn't work that way. Okay, it's neurological in nature. When we're talking about compression, we're trying to get after these Ruffini endings, which sit a little bit deeper into the tissues, and they respond to deep sustained pressure, i.e. compression. Okay? Whether that's with my hands or a tool or this compressive band of rock floss that we're going to be using in the course, when stimulated, these Ruffini endings have a down regulatory response on the nervous system. This down regulatory response decreases our sympathetic drive, and in absence of our sympathetic drive, we can get parasympathetic rest and digest to happen. So if we're resting and digesting and all nice and easy, this is where tissue mobility and pain can take in big time, right? If I'm fight or flight running from a bear, how much mobility am I going to have and how much pain am I going to be sensing? Everything, right? If I'm down regulated, rest and digest, parasympathetic, tissue mobility and pain is going to take a big front hold in there. With this, we have to understand that the research on compressive therapies is limited. Okay, what we are finding is some pilot studies, some anecdotal research, some case studies, some systematic reviews. But the big argument with compressive therapies is it placebo? Well, I don't like the word placebo, so I'm going to change that to perception, right? And if we're looking at perception, what they found in this study is that there wasn't a great change in range of motion, shoulder range of motion, from the test to control groups. But those who were tested or had compressive therapies on their shoulder felt like they had a greater range of motion. It wasn't measurable, but they felt like they had it. Maybe, just maybe, and I think this is true, perception can become reality. If I think I have better range of motion, might I use this shoulder a little bit more frequently, more quality, more quantity, anything, or have trust of bigger movements? Yeah, I would like to believe so. Okay. So perception can be, or placebo can be, a very, very beneficial part of our treatment. Last little thing on our compressive chapter is movement. Again, okay, we can always treat and train movement. Again, using this as an external cue or a carrot on a stick, leading this donkey, don't call your patients and clients donkeys, leading this donkey around. Gray Cook says that pain changes movement in unpredictable ways. I think that our goal as therapists and providers and clinicians and treatment people should be changing these movement patterns to more predictable things through external cues, and then slowly weaning them off that. And we'll discuss this pyramid of awareness later today, so that their movement patterns become more subconsciously functional. They don't even know or need this feedback to move effective and efficiently. Okay. So an example of this with the compressive therapies is a bilateral helix for glenohumeral external rotation, as well as potentially, you can see across the back here, scapular retraction as well. So if the individual shown here were to drift into this slouch position, they would feel stretch on that red rock floss band there, and they would get feedback to be more open. Okay. Our next chapter is going to be treating with kinesiology taping. When we're talking about the shoulder in the full course, specifically, we're going to be looking for pain and neural feedback, or yes, again, you thought of it, movement, right? Movement is crucial. Movement is what we're treating always, okay? So briefly, when we're looking into pain, we have to understand that the brain's predictive capacity, again, this motor control idea, depends on the accuracy of the information received. Think phantom limb pain. When we don't get accurate information from a limb that's gone, okay, our brain inputs pain as a signal to try to get its attention to focus on that area. Through time and repetition, a lot of training, training for the individual, we can mitigate this pain signal being sent to the brain from a limb that doesn't even exist. Okay, that predictive capacity is crucial. This video that we have here is a guy in Germany, I believe, walking around with a red wagon, little radio flyer wagon, filled with 99 cell phones. Okay, every single one of these cell phones has their Google Maps on, as if they're driving, and you can see, and we'll go through this with a bigger, better example in the full course. But that map on the upper right-hand side here starts to go from green to red. And what we'll see in the full course is that that map expands to being red, like they're in Germany. So I don't know, 5 kilometers out, right? And it screws up Google's algorithm to predict what the traffic is doing, even though, as you can see, there's nobody on the streets. Our brain works in a very similar manner. When we don't get accurate information, we have 99 red wagon cell phone things sitting in our left big toe, that's going to screw up our brain's predictive capacity or understanding of where that thing is in space. And maybe we're going to have to start using our shoulder to adapt away from that, because now we're centering our gravity over here. Or maybe that predictive capacity is screwed up right in my shoulder, right? We'll understand these so that we can treat them with kinesiology tape, with compressive and decompressive therapies, with corrective exercises. Okay. So if you've worked with kinesiology tape before or not, we'll start you from the basics. If you've never worked with kinesiology tape, we'll show you how to cut the tape. We'll show you how to apply the tape, and then show you variations of how to work with pain, because pain might be the rate limiting factor to having adequate movement patterns for this individual. Next part of our kinesiology taping is going to be providing, again, neural feedback or an external cue for better movement. So if we have this anteriorly tipped or winging shoulder blade, we might need more engagement of the serratus anterior area. Okay, we're not taping muscles, we're taping movement. So if we want serratus anterior to cue in and suck that shoulder blade down into the rib cage, if I put tape in this manner and I were to drift my shoulder anteriorly, I would feel stretch across these 2 pieces of black tape here, and thus, knock, knock, put in head, get your shoulder blade tucked underneath, okay? So the reason I like using kinesiology tape as a external cue or a neural feedback approach is it forces the individual to use their own muscles to go through this. It's not a brace. It's not a rigid shoulder cuff that we can put on somebody holding them in this position and using as a crutch, right? They have to engage their own serratus anterior to get that shoulder blade tucked under this position. And then our last chapter of treatment techniques, corrective exercise strategies. Again, I don't like the word corrective because it implies that something was not correct to start with. We're just trying to take somebody from here and move them here, or regress them down to here. And we'll discuss in the course when and why and how to regress with isometrics or concentrics or eccentric exercises, and with a local or global focus. Just like our kinesiology taping chapter, if you have zero rehab background whatsoever, we're going to start with the basics. We'll make them interesting enough for those of you who have a basis in rehab that will be able to think outside the box and glean some more cool information from. But wherever your rehab knowledge sits, we're going to give you applicable exercises based off of the assessment for the person in front of you. And with that being said, then our assessment is going to be our guide. Some of the best assessments that we can do, a lunge or something like that for the hip, for example, or a diamond test, turn into a exercise, turn into a corrective strategy for that individual. And when we're giving them these exercises as take-home homework, don't use the word homework because nobody likes doing homework. If they're not doing them, that's your fault, not theirs. Okay. I hate when I hear somebody say, failed PT. Like, how did you fail PT? They were lacking education. They didn't know why they were given the exercises in the first place. Okay. So do they understand their exercises? Do they understand what this aberrant movement pattern is leading them to with their pain or chief complaint anyways? Okay. Do they understand that it'll be less time, money, and effort if they do their exercises? Does it match their goals, or is it reasonable to them? Do they actually have the equipment necessary to do that? Okay. These exercises that you're giving them, these corrective strategies, have to address all of these things, their why of their issue and why it's there in the first place before they're going to be compliant. Okay. And at the end of the day, I always tell people, you didn't get hurt on a table. I can work on the table. I can be a catalyst to get you feeling a little bit better, but these strategies are going to keep you off this table. They're going to keep you out of my office entirely. If I'm doing a good job as a provider, I shouldn't be seeing people. My job is to get people moving better. If they're stepping foot in my office every 2 days, they're not getting better per se, right? So education is where these things take a jumping point from. With our corrective exercise chapter, we're going to start with a understanding of what an isometric is, what an eccentric is, what a concentric contraction is, and where these might take place in this rehabilitation process. Okay. So an isometric example would be like a vibration ball hold, just holding a ball statically and going through a hold. Well, that ball is shaking up over here. I'm trying to pack my shoulder, maybe tuck it in, anti-wing it, right? And I'm just going through different ranges of motion with that, progressing that as necessary. With this isometric phase, what we're looking for is this shakiness, this perturbation of muscle fatigue per se. And this is where potentially neuromuscular learning or muscle memory is working and being built upon, right? This is generally where we want to start somebody who can't feel something engaging, okay? To get that feeling of, hey, do you feel your glute firing here? Do you feel your supraspinatus firing here? Do you feel your levator firing here? We need to start with an isometric contraction in a specific range of motion so that they can understand what the goal is in the first place. Then we can move along to something like an eccentric, okay? If we're thinking throwing, hitting, swinging, or overhead motions, we can go through slow, controlled focus with this, right? The whole point of an eccentric is potentially tendinous rehab or building stability. It's smooth, okay? If we're shaking through something, we don't have control over all of this range. Or if we're going smooth, bounce, our brain is feeling a threat in that specific range of motion, and it's going to shake. When we get that shake, we get potentially muscular spasm or sprain, strain, tear potentially, and we need to build that smoothness across that range of motion. And then, of course, we can go to our concentric, maybe like a bicep curl or something, right? Because why not do more bicep curls? Okay. Next portion of this chapter is going to get into our local versus global focus. Just like we had a local assessment of the shoulder and a global assessment of the shoulder, we're going to have a local exercise base to choose from and a global exercise base to choose from. Because, like Ida Rolf says, where you think it is, it ain't. This is that victim versus culprit idea, and understanding that there might be other elephants in the room. Perhaps my hip is the culprit and my shoulder is being the victim of this. Well, let's go through something that addresses that. Or maybe it's my thoracic spine that's being too stable when it needs to be more mobile, and we need to mobilize that. Okay. This is beating up our scapulothoracic joint, which needs more stability, and we can build that up too. Okay. So in our course, we will give plenty of examples and demonstrate and practice them with each other live, okay, and ask questions and all this great stuff based off of our assessments. The other beauty here is all of these exercises are for the same reason. This is all of our, not all of our, this is 3 examples for scapulothoracic joint stability. Okay? There's a billion that we can choose from, but which one matches our assessment best for that individual in front of us? And we'll discuss that. I mentioned the thoracic spine. We'll go through examples of that, as well as the hip, and maybe even like breathing and fun stuff like that too. Okay. We also must know when to progress or graduate our patients and clients, as well as regress or give them a step back. Okay. When do we move up or down or lateral? Maybe it's the same exercise, just with the same intent, just with a pattern that fits them better. And learning to be malleable, just like our treatment, yet and open to change is crucial. Okay. Mitch Hauschild says in his book, and this quote really stuck out with me, when we forget about proper exercise progressions and skip over basic movements or foundational movements in favor of more complex ones or sexy ones, we are layering strength on top of dysfunction. Or, simply put, we're training a bad habit. Okay, we need to break it down into our TUMs, as I call them, tiny, unsexy movements, which are going to allow big, sexy movements to happen easier, faster, more fluent, efficient, powerful, all these great things. That is athleticism. Okay? Just because it's on Instagram doesn't mean it's for you. Okay? So, regressions. We have to get over the negative connotation of downgrading somebody. Rather put, I like saying, hey, we're stepping back to create space for opportunity. Kobe here, rest in peace, was fantastic at taking a step back to throw up a shot. That space between him and the defender created an opportunity for a score. Okay. I didn't play basketball, so don't make fun of my lingo here. Right. On the other side, we are going to understand when to progress and how to progress and what steps we have to take to get there. Progression is always fun. Because it's always fun, I always like to try to start people at the lowest area or lowest exercise that I think they're capable of doing. Don't make it like a we're going to tear them down so we can build them up kind of thing. More so, we're going to start them at something that we can easily graduate from in within that visit or within the next visit, so that it creates this buy-in process, right? It creates wins that match their goals. That's fun for them. Okay. On the bottom here, you'll see this pyramid. And this is what I call the awareness pyramid. And we're going to talk about this at length in our full course too. At the very top, we have subconscious dysfunction. The individual doesn't even know, they're subconscious to the fact that there's an issue there. There's nothing going on. There's no pain, there's no complaints, there's no symptoms or signs or anything like that until they raise consciousness to that. So that's that second portion down here, okay? This conscious dysfunction, it's still dysfunctional, but they're aware of it because of pain threshold being met or something torn or an issue arose in there. That's where people seek out therapists or providers or clinicians, okay? Conscious function on the opposites, or on the next progression of this, is they're still aware of it, but they're working with somebody like us to make it more functional. Through time and repetition, as you'll see on that left-hand side there, it's going to become subconsciously functional. They don't even know that they are throwing with the best possible biomechanics, right? They don't know that they are running with proper arm swing that's not beating up their upper trap or anything like that, okay? At the end of the day, our goal with these exercises is fix the why. Now, I know legally within scopes of practice around the nation and the world, we can't say fix with anything, but this is a tagline, okay? So fix the why. Why is that issue there in the first place? And throughout this entire course, I hope that we can deliver the idea of why, okay? Why are they experiencing what they're experiencing? And let's attack that, because that'll get faster responses, faster outcome measures being met, and faster people out of our door doing things that they love doing. Okay? So our full course will include further expanded sections, more assessment, more screening, more patient history intake, more anatomy, more understanding of what the injuries and mechanisms of injuries of the shoulder are for rotational athletes, and assessments, kinesiology taping, corrective exercises, demos. Okay, that's the biggest takeaway here: is demonstrations, time spent with me, your favorite person. I know, just kidding. As well as each other. Okay, so one-on-one availability not just from me, but the entire class, that we can brainstorm and nerd out and work with each other on developing these strategies for addressing and understanding shoulder injuries for these athletes. Okay. And so, with that, there's going to be plenty of time for applications, whether that's a treatment application or an assessment demonstration per se. And we can feel what these exercises do for ourselves and what's engaging and what's disengaging and work with that. Okay. This is all with the live course. After the live course, there's going to be a downloadable version, which you're more than welcome to purchase as well. But regardless of which version you may choose to take, there's going to be an early bird special. Okay, so early bird special for the full course live webcast is going to end about a month prior to the course, and a downloadable version will be offered slightly cheaper because we're losing that Q&A availability, slightly cheaper than the full live course, but it won't be available for another 1 to 2 weeks after for editing and stuff like that after the live course. Okay, so last thing I want to say is thank you guys for downloading this mini session, this teaser of sorts for this course. I'm beyond grateful for this opportunity to learn with you, to nerd out with you, and really just gain a better understanding and demystify what that shoulder is doing for our clients and patients. Okay. So again, thank you. If you guys want to jump straight to the website, by all means, go for it. Minnesota-movement.com. The course should be on there shortly if it's not already. And if you have any questions, reach out to me. Information's right above me here. So either Instagram, email, both are fantastic ways. Thank you guys, and have a great day.